UnityPoint has partnered with PCI and Dr. Jeffrey Nassif to bring you this event. My name is Jen Reeve, and I'm the Advanced Practice Nurse for Surgical Services. Tonight, I have the great honor of telling you a little bit more about our program and introducing Dr. Nassif. Next is one of the slides we are most proud of. These are the many honors and awards we have received. A couple I would like to note and draw your attention to. We are DNV certified, which means we follow DNV standards as well as guidelines from the American Academy of Orthopedic Surgeons. We have also received a 5-star quality rating by CMS. In addition, we are known as a magnet organization, which means we have been recognized for our nursing excellence. Most recently, we have received notification that we are also a top 100 hospital. Next, I will tell you more about our program and the many stops along the way. The first stop in your total joint experience is the STAR Clinic. Here is where the STAR nurse will review your health history, medications, lab work, and any documents necessary for surgery. The STAR Clinic works closely with PCI, Joint Academy, and anesthesia to ensure you are healthy enough for elective surgery. Here, we will also ask what matters most and how can we make you more comfortable to ensure your needs are met. The second stop in your total joint experience is the Joint Academy. Here, we will provide you with pre-op education, including what to expect during your surgery, review any pre- or post-operative exercises, and answer any questions or concerns you may have. At this time, you will also receive a unit and room tour of Force Center. The third stop in your total joint experience is surgery. Surgery encompasses 3 departments: Surgicare or pre-op, the operating room, and PACU, also known as the recovery room. In Surgicare, you will be checked in. We will also prepare you for surgery, including inserting an IV, giving fluids, and obtaining baseline assessments. Nursing will ensure all pre-op orders are completed. At this time, you may also receive a nerve block if ordered by your provider for post-op pain control. From here, the OR circulator will interview you and wheel you into the OR. The operating room is where the actual surgery takes place. It is known for being very cold. However, we will keep you warm and cozy, all while placing our monitors and devices on you. The OR team works closely with the surgeon and anesthesiologist throughout the surgery. Here, you may receive a spinal anesthetic or general anesthesia. The PACU, or the recovery room, is where you will wake up and be stabilized after surgery. The focus will be on pain control, nausea relief, and overall comfort. Nursing will complete any post-operative assessments and transport you to the floor when you are stable. The fourth stop in your total joint experience is Force Center Orthopedics. Here, you will continue recovering and start the rehab process. Nursing will complete any post-operative checks and offer many comfort measures such as offering ice, elevation, aromatherapy, or music. We will also encourage infection prevention measures such as incentive spirometry and coughing and deep breathing. The fifth and final stop in your total joint experience is therapy. Therapy is extremely important in maintaining the life of your joint. Here, we will help you ambulate and work through mobility exercises. And now, I have the great honor of introducing the man of the hour himself. He specializes in hip, knee, and shoulder replacement surgery. He received his bachelor's in science from the University of Iowa and his MD from the University of Iowa Carver College of Medicine. He completed his residency at the University of Kentucky Lexington and received his certification from the American Board of Orthopedic Surgery. He is also a member of many local and national associations. Dr. Jeffrey Nassif.
Okie dokie, so we're going to be talking tonight about the only thing I know anything about, joint replacement surgery. And we'll also talk about surgical and non-surgical treatments for shoulder, hip, and knee arthritis. Jen just showed you a picture of me. Here's another picture of me, and maybe you can tell which one was recently and which one was I'm not going to put it on. So the topics tonight, we'll go over some general anatomy of the shoulder, hip, and knee. We'll talk about the two main types of arthritis, which are osteoarthritis and rheumatoid arthritis. There are several other types, but we won't talk about those. Symptoms of joint disorders, how we assess joints, how we treat them surgically and non-surgically, and we'll talk briefly about outpatient surgery also. So to begin with, the anatomy of the hip consists of your pelvic bone and your femur bone. There's what we call a femoral head, which is the ball of the ball and socket joint, and then the socket of the ball and socket joint. The socket's part of your pelvis. The ball is part of the top part of your femur bone. The knee joint is the opposite end of your femur bone, which is the top of your knee, the femur. The bottom part of your knee is your tibia, your shin bone, and then your kneecap. There are four major ligaments in a knee that help stabilize a knee, which are basically like tight rubber bands. There's the two on the outside portions of your knee called the medial and lateral collateral ligaments. And then on the inside part of the knee, there's the cruciate ligaments or crossing ligaments, which are the anterior and posterior cruciate ligaments. This is just a pictorial showing the ligaments on the outside part of the knee. The cruciate ligaments are right in here. Cartilage is basically a rubbery type tissue, which are caps on the ends of the bones inside the joint. It protects the ends of the bones and provides a smooth gliding surface for the bone. There's cartilage on the end of inside every joint, no matter if it's your finger, your toe, or your hip, or your knee, and they're basically caps on the ends of the bone. There's also cartilage behind the kneecap. Same with the hip. The femoral head of the ball is covered with cartilage, and what you can't see really here is the socket. If you remove the ball, the socket's covered with cartilage also. Same sort of thing in the shoulder. There's a ball and socket joint. The top of your humerus bone is called your humeral head, which is the ball of the ball and socket joint. Your shoulder blade has the socket, that's called the glenoid, and both of those are covered with cartilage with some ligaments surrounding those also. Arthritis is defined as an inflammation of a joint. There's over 100 different types of arthritis affecting around 43 million Americans annually. There's two main types of arthritis, osteoarthritis and rheumatoid arthritis. Rheumatoid arthritis is a much less common form of arthritis. It's a little more disabling because it's a systemic disease and it affects a person's whole well-being. Rheumatoid arthritis is a systemic inflammatory condition affecting joints and other portions of the body. It affects the lubrication of the joint, which is a synovial fluid, by increasing pressure in the joints. This thickens the synovium and damages the cartilage in the particular joint. This is an example of a hand with rheumatoid arthritis, and the difference between this and osteoarthritis is this is affecting basically all the joints in the wrist, the majority of the joints in the finger, where osteoarthritis may just affect one joint and not all of the joints. Osteoarthritis is a much more common form of arthritis. It's exponentially growing year by year. It affects an awful lot of people and is continuing to affect more and more people. It's the wear and tear kind of arthritis that we talk about. It basically affects one joint at a time, although some people get it in multiple joints, but it's not a systemic disease like rheumatoid arthritis. It's a part of a wear and tear from aging and other things such as sporting and fractures and dislocations of the joints. It's a very manageable, treatable condition. This is an example of a hip with arthritis. So the X-ray on the left shows a round ball with a round socket, and then there's this black gap in between the ball and the socket. You can't see cartilage by X-ray. and it's the gap between the two that we assess, and this has a normal gap between the ball and the socket. Compare that to the x-ray on the right. There is no gap up there any longer. There's no gap throughout. You have these extra things around here. Those are bone spurs throughout the hip. Similar thing with the knee. On the inside and the outside, we see a nice gap. With an arthritic knee, this particular one has a gap on the outside part of the knee, but on the inside part of the knee, there is no gap, and there's a lot of spurring throughout the knee. We'll see a similar thing with shoulders. Nice cartilage gap in between the ball and the socket. Well, over here, there's a little gap on top. There's no gap down below. There's a big bone spur here. The ball's not round here like it is over here. Symptoms of arthritis, I'm sure I don't need to tell a lot of you. You have pain in your joint. You can get joint swelling either with fluid on the joint or the soft tissue swell, which will cause an enlarging of the joint. All this leads to stiffness in your joint, which leads to decreased activity and an impaired lifestyle. On physical exam, we see decreased range of motion of whatever joint's involved. When we palpate your joint, there's tenderness across there. With the hand, you can see deformities across the hand. With what I deal with the knee in particular, you can get bow-legged or knock-kneed with that, depending on the type of arthritis you have. We talked about soft tissue swelling and fluid all in the joint. All of this leads to weakness of the muscles surrounding the joint. This particular person has arthritis on the inside part of the knee. When a person has it mostly on the inside part of the knee, they'll get a bow-legged deformity. When it's more on the outside part of the knee, they'll get a knock-knee deformity. This is kind of a busy slide, just talking about a bunch of different things that can lead to arthritis. Now we'll get to treatment. We start out with diet and exercise. Good nutrition promotes overall good health. Excessive weight on the lower extremities especially creates increased pressure, which can aggravate arthritis. I tell people, and a lot of studies will tell us that 6 times your body weight goes through your hip and knee joint with every step you take. And if you lose 10 pounds, your hip and knee will feel like it lost 60 pounds. And it does make a big, big difference with arthritis and helping to minimize some of the symptoms by losing some weight. We send almost everybody to physical therapy. Exercise improves joint mobility. They can help out with range of motion. They keep your joints flexible. And again, everybody's muscles around their joint gets weakened with arthritis. And physical therapy helps to strengthen the muscles around your joint. From there, there's different treatments of walking devices, braces, and heel wedges. Canes or walkers can significantly unload lower extremity joints, which can help with some pain relief. There's different types of braces we wear on knees. They're simple as neoprene knee sleeves, which can keep your knee warm, which can correlate to improvement in symptoms. To big hinge braces, which have pluses and minuses. Sometimes they're too big and bulky to use, but some people, they're beneficial. They help put counter pressure on your knee, so if you have a bow-legged deformity, it pushes on your knee to make it more of a knock knee to take the pressure off the bad inside part of the knee and put it on the good outside part of the knee, or vice versa for bow-leg or knock knee deformities. And sometimes we put wedges in people's shoes. What those wedges do is they take the pressure off a bad part of your knee and put it on the good part of your knee. For people that are standing a lot, those can help quite a bit. From there, we talk about different medications and nutritional support. Tylenol is our initial treatment for pain. It's a simple pain reliever. It's a very safe medicine to take, and we encourage people to do that. From there, we talk about non-steroidal anti-inflammatories like Advil or Aleve, or there's multiple prescription medications. Those aren't quite as easy on a person's system. However, they're not just pain medications like Tylenol is either. So Tylenol, the only benefit, which is a good benefit, it's a pain reliever. Anti-inflammatories also work to help with inflammation and pain relief. So they do have an additive benefit, and some people they help a little better too. From there, we talk about different analgesics, which are pain medicines. We don't prescribe as much at this point, but occasionally will do for flares of arthritis. The rheumatologist, a little more than we do, will provide steroids for people too. So sometimes, medicines like prednisone or Medrol dose pack, they're potent anti-inflammatories, and they're useful for flares of arthritis, for osteoarthritis, but sometimes people on chronic steroids for inflammatory arthritis, such as rheumatoid arthritis. There's different injections we use when those don't help. The two types are cortisone. Cortisone, I tell people, is a potent anti-inflammatory. It's like taking 50 Advil all at once right in the knee joint. They work on just about everybody, no matter how bad the arthritis is. The problem with them is that worse your arthritis is, the more unpredictable the length of time they last. So when a person has more mild to moderate arthritis, they tend to last quite a bit longer. When you have more severe arthritis, some people they last a week or two, and some people they can last a couple of months, and it really varies a lot. From there, the other type of injection is hyaluron, which is hyaluronic acid. That, I tell people, is more like a joint lubrication. It is not an anti-inflammatory. It's designed to bring a lubrication, particularly in the knee joint. It's only FDA approved for the knee joint, where that's being eroded away from the arthritis. That works best with early to moderate arthritis, less well so on moderate to severe. When it's bone on bone, it really doesn't play a big role. It doesn't tend to help predictably very much. The only times we try it is if a person's not a surgical candidate and we've tried everything else, we'll try that sometimes. Nutritional supports are this glucosamine and chondroitin sulfate. They're naturally occurring substances in everybody. When used in the correct dosage, can help with pain. There's some things in the lay press that say they bring back cartilage. It doesn't do that, and it can't do that. But it's been compared to placebo, and it can help with people's arthritic pain. Once you've failed those non-surgical treatments, we talk about joint replacements. You should consider a joint replacement when your pain negatively affects your daily activities. When you've tried conservative treatments and those conservative treatments are no longer helping to allow you to do the normal activities that you want to do. And we like to see essentially bone-on-bone arthritis by x-ray. In simple terms, a joint replacement is resurfacing the ends of the damaged bone. So you can think of it as putting a cap on the end of your bone. So we're not cutting off your shoulder, or cutting off your knee and putting the whole thing back in there. We're basically resurfacing the ends of the bone and placing metal and plastic in there. You're going to see this slide a lot, but the bottom line is what I just talked about. So what we're doing is we're resurfacing the ends of the bone with metal and plastic. This is what a pictorial of what one looks like. So this is your knee joint, the end of your thigh bone, the top of your shin bone. If you think of the end of your thigh bone like my fist, basically we remove the end of the thigh bone, place a metal cap on that. The top of your shin bone, we sort of make a flat cut on top of that. These silvery things are made out of metal, and then that plastic here is called ultra-high molecular weight polyethylene. It's a type of a plastic. And that's what a knee replacement looks like. That's what one looks like by x-ray. This is looking at it straight on. This is looking at it from the side view. So it's basically a cap on the end of the bone here. The top of the shin bone has a flat cut. The plastic is like cartilage, that you can't see the plastic by x-ray, so you see the black gap in between. Your kneecap, I get this question a lot, do I get a new kneecap? The answer to that is yes and no. So the part of your kneecap that you touch, the outside part of it is still your bone, but the inside part we remove and place a metal cap on that. This is just showing a metallic line in there, which is a metallic marker showing that you have a kneecap in there, a plastic kneecap in there also. There are also partial knee replacements. This is what one looks like. Most commonly, it's the inside part of the knee. So if a person's inside part of the knee is bone on bone, they have a completely normal outside part of the knee. All their ligaments are normal. You can accept a little bit of arthritis behind the kneecap. You would be a candidate for a partial knee replacement. Partial knee replacements have the benefit of they're much smaller operations. They're a little easier recovery, and they work very, very well. People tend to function, if you look at intricate function scores, not just normal daily activities, meaning people that would do sporting activities and such. People actually function a little bit better with a partial knee replacement than a total knee replacement, mostly because all the ligaments are still intact, where they're not with a total knee replacement. We have to remove some of your ligaments to put the total knee replacement in. There's been improvements over time with recovery. We now use smaller incisions than used to be used for all of these joint replacements for the shoulders and the hip and the knee. Those had all been shown by having less blood loss, less perioperative pain, and a little quicker recovery with the smaller incisions. Again, the same sort of thing where hip replacement is resurfacing the ends of the bone. This is what one looks like. This is your femur bone. Your ball's supposed to be here. We removed your ball, replace this metal device inside your femur bone. There's a new ball on top of that. We core out your socket and make that smooth. You get a metal socket that goes inside that. A lot of times there's screws that will hold that in temporarily. There's a plastic bearing surface here and then a new ball on top. By x-ray, this is what one looks like. These are just two different brands of the same thing. So we remove your ball here, place this metal device inside. You have a new ball here. We core out the socket, and there's a new socket there, which you can't see as a plastic bearing surface between the two. Shoulder replacement is a similar sort of thing. Shoulder replacement looks very similar to a hip replacement, and there's a metal device that goes inside your arm bone, the new ball, and most of the sockets are made out of plastic. This is what one looks like, with the metal stem inside the bone, a new ball. Right here, which kind of looks black and white, is the plastic socket. That's called an anatomic shoulder replacement. There's also something called a reverse shoulder replacement. A reverse shoulder replacement actually has a ball on the socket side, and the socket, which you can't see very well here, is partly plastic on the ball side. That's designed for people that don't have a functioning rotator cuff. So it's either designed for arthritis plus a rotator cuff tear, or simply a large rotator cuff tear that's not repairable. There's newer technologies nowadays that have changed over the last 15 or 20 years. Those consist of alternative bearing surfaces. We use a lot of ceramics now, mostly in the hip. Some ceramic on new plastic, some ceramic on ceramics, and we did talk briefly about minimally invasive surgery. The latest technology in the last 5 years or so has been outpatient joint replacement surgery. We do a lot with our anesthesia colleagues in perioperative pain management, which has helped with quicker needs of recovery. You can either have this outpatient surgery at the hospital where you go home the same day, or at the outpatient surgery center. The way we do things, you have a little bit quicker needs to recovery. There's a significant decreased cost to the healthcare system. There's been some very, very, very preliminary early evidence of a lower risk of infection than ambulatory surgery centers compared to hospitals, but this is very preliminary. I'm going to show you a video here. This is somebody that had a knee replacement 1 month post-operatively. If I can get this to work, put it here. This is in our office. This is her walking without assistive devices a month after surgery. This is kind of the way we expect people afterwards. People do very well very quickly. This is another video showing her knee range of motion. This one is a little bit longer, but this will show you how she's doing with knee range of motion at 1 month after surgery. She'll kind of show you here in just a minute. So she's able to straighten her leg all the way, and she'll scoot over a little bit here to show us how she can bend her knee all the way also. And this is what we want to see afterwards. We want to see people's function to get better quickly nowadays compared to how it used to be. This is a man who's 5 weeks after having both of his knees replaced. We did those a week apart. This is his knee bending in the office and his knee straightening in the office. Full range of motion, and again, him walking without any assistive devices in our office 5 weeks after surgery. So it can be done. There are major benefits of all joint replacements. They can significantly reduce or eliminate your pain. They'll enhance your mobility, and they can improve your quality of life to return you back to the normal activities that you want to do, including low-impact sporting activities. One of the big things nowadays is what we call multimodal pain management for all joint replacements. We're doing a lot of special things with knee replacements. There's something called iovera, which we've just started doing the last couple of years. It works very, very well. What iovera is, it's a kind of what we call a cryotherapy. Either our nurse practitioners in the office or one of the anesthesiologists in the hospital. The best way I can describe this is they use this freezer probe type thing that freezes the superficial sensory nerves on the front part of your knee, and it makes the front part of your knee numb for 3 to 5 months. It works we do this about 2 weeks pre-op. It works very, very well for incisional pain and helping with range of motion because the front part of your knee literally doesn't work, or doesn't hurt. It doesn't affect the back part of your knee, but it really works well for post-operative pain. As Jen told you, the day of surgery with the anesthesiologist will do something called an adductor canal block, which is another nerve block that helps with immediate post-operative pain. We basically don't use any IV narcotics anymore because of these other measures that we do. When I first started here, everybody was on a push-button morphine drip. There were horrible complications with that and horrible problems with that. None of that's done anymore. We don't use any sort of IV medicines anymore. We're able to use oral medicines. We now know that there are multiple different pain receptors in a person's body, not just narcotic pain receptors. There's receptors for Tylenol, there's receptors for some pain medicines, there's nerve receptors, and there's anti-inflammatory receptors. So everybody gets sort of a cocktail of multiple different medications to help their pain, which significantly minimize the use of narcotics after surgery. So with all these modalities, with minimally invasive incisions, with muscle-sparing approaches, in the operating room, which we didn't talk about much, we do something called a periarticular injection and an intermuscular and intertendinous and subcutaneous injections. Basically, we have a mixture of medications that we inject around your knee joint and your hip joint and your shoulder joint that helps affect those pain receptors right at the spot to help minimize your post-operative pain, and that helps a lot. There's a relatively new thing called TXA, which is tranexamic acid, which helps significantly decrease blood loss around the time of joint replacement surgery. Again, when I first came here about 25 years ago, about a third of people would get a blood transfusion after a hip and knee replacement. Nowadays, that's almost unheard of. Pretty much nobody does, and it's basically because of these minimally invasive techniques and that TXA really makes a big difference. Post-operatively, before you go home, you have to avoid, you have to tolerate oral intake. Your pain has to be under good control and all your vital signs have to be okay. Before discharge, you'll have laboratory tests, basically hemoglobin to make sure everything's okay with that. You'll have x-ray and physical therapy will get you up walking and teach you home exercises to do. This is where we talk about this. The day of surgery, you'll need to ambulate down the hospital floor or wherever you're having things done at. You'll have to bend your knee a certain amount. Your pain will have to be under good control. We actually walk you up and down stairs before you go home, so you're pretty darn independent before you leave the hospital or the surgery center. If you stay in the hospital, it's most commonly one night. It's pretty rare for a person to stay 2 nights anymore. You'll get up walking with a walker or crutches. Again, the multimodal pain management, which will help with recovery. You resume normal activities at 3 to 6 weeks. You resume normal sporting activities at 1 to 2 months. There are activity restrictions after hip and knee and shoulder replacements. With hip and knees in particular, we don't like people to run, maybe jogging for exercise. No jumping sports like basketball, and we don't like people that carry more than 75 or 80 pounds on a regular basis. I kind of tell people these artificial joints are made out of metal and plastic. They're not designed for high impact use. They're designed for everyday walking and biking and low impact things, but you can do those things, but if you do those things, it'll wear them out a lot quicker. And so we recommend you not do those things. There are complications with any surgery, particular joint replacements, infection, nerve damage, dislocations of the joint, and the wearing and loosening of the joint. Physical therapy is with all of these except hip replacements. With hip replacements, they teach you some exercise you do in the hospital or surgery center, and you walk, and that's really all the exercise or therapy you have. With shoulders and knees, there's a lot of supervised physical therapy afterwards. We send you home with medications and encourage a healthy diet. You have routine follow-up with it at the doctor's office at 4 to 6 weeks, 6 months, and every 2 to 3 years the rest of your life. The reason for that is we can tell abnormalities, meaning wear on an x-ray, sometimes before they cause you symptoms. And sometimes, if we catch it early enough, the fix is easier, such as changing the plastic instead of the whole thing. That's why we do that trade every 2 or 3 years for it. Let's get that. So requirements to have surgery at an outpatient surgery center. In general, it's less than 80 years old. Sometimes we've done a couple people older than that. 1 or 2 other health problems like diabetes or heart disease. Your body mass index has to be below 40, and that's a good general rule for any sort of joint replacement, whether it's done in the hospital or the surgery center. There's been a whole bunch of studies on hip and knee replacements. That's all I'm talking about right now, not shoulders and not gallbladders or anything else. That basically show that if your body mass index is below 30, your risks around the time of surgery are normal. When they're between 30 and 40, they're elevated, but not prohibitively elevated. When they're above 40, it's recommended you not do the operation because the risks around the time of surgery and afterwards are too great to do this. You should have good family support at home with you when you go home. You can't have a pacemaker or a history of anesthetic complications if your surgery is done at the outpatient surgery center. In closing, your symptoms should be diagnosed early to manage those. There's many ways to treat arthritis, both surgically and non-surgically. And I just want to show you one last video of a patient, a young patient that had an outpatient joint replacement and had a good experience.
Being an avid runner, putting on over 100 miles a week, running, I knew that something wasn't right when I actually I could run, but I couldn't sleep through the night anymore. My lifestyle has changed considerably, being running over 100 miles a week to now swimming and limping out of the pool, to doing step masters and step mills and limping getting off of them, and kind of being tired of asking the question, what's wrong with you at your age? I am excited to the fact that I'll come in and I'll go out, and I've already have physical therapy scheduled for that Friday after Tuesday. And it just makes sense not to be introduced into a hospital in December where there's a lot of sickness and illness.
Ed is really a perfect patient to have this done. He's young, he's very, very active. He's been through a lot of troubles with his knee. He's had a couple of surgeries, he's gone through exhaustive physical therapy and braces and different shots, and despite that, his pain and process is getting a lot worse. It's severely affecting his daily activities, and it also keeps him awake at night. And for this reason, we felt he'd be a good candidate for a knee replacement and a good candidate to be done as an outpatient.
Before we started doing this, it always seemed like a very scary experience to a lot of people, and they were really told that, hey, this is going to be a tough recovery. And while it still is a big surgery, I think we're showing people more and more that they can really get moving after this and really get back to their active lifestyles quicker than probably what they had previously thought they could do.
Joint replacement surgeries with hips and knees and for shoulders, for that matter, are very, very safe operations nowadays. They're big operations, and they can't be said that they're not. They are big operations, but our techniques nowadays are very, very good. Our surgeries with the minimally invasive techniques really minimize risks around the time of surgery, minimize blood loss. We're able to get people up walking right away. A lot of people after surgery tell us the post-surgical pain is much less than it was before surgery, and very, very happy afterwards. The biggest complaint we get from people afterwards is, why do they wait so long? Because it basically gets your lifestyle back to normal, where it hasn't been that way in years and years.
Long gone are the days where we used to have people sit in bed for a couple of days or even weeks before we got them up and moving. So patients get up right away when they're in the recovery room at the surgery center with the surgery center staff. And then typically as soon as they get to therapy with us, we have them up moving around. Getting up and walking is probably the biggest part of the recovery process. And we really encourage them to be up multiple times throughout the day, getting around and walking. We really encourage these patients to not just rely on their loved ones for help at home, but that they need to start being independent right away from the start. Ed did great right from the start. You know, that first day of surgery, I mean, he was ready to go, he was excited, he was feeling good, and he really just jumped right out of the wheelchair when he got there, and you know, we were able to push him through all of his walking and his exercise with no problems. I think with Ed too, he really showed the positive attitude can make a big difference, and I mean, when we put him in the car to leave, he was smiling and waving, and he was really feeling upbeat and good about this stuff. So I think he's a great example of, you know, how successful this procedure can be as an outpatient surgery.
The care that I received from start to finish was just incredible, and the expectation I had about being able to put my foot down, being back at the gym 8 weeks later, far exceeded any expectations. The key for me was to get back with my kids. I really feel I have my life back. I'm going up and down the stairs without pain. I'm getting back on the treadmill. I'm walking flat-footed again, which I haven't done in 2 years. And it was the best decision for me, with the help of my surgical team, my doctors, my physicians, and the care that I received through PCI and the surgery center.
That's all I have. Any questions?
Back in 2016, the new thing coming out was the 3D replacement. Is that still valid today?
No, that was sort of a big craze for a little while. That 3D thing was a semi-custom knee replacement, and what they were doing was they were kind of making the implants asymmetric. So part of a knee replacement is cutting the bone. The other part of a knee replacement is doing what we call ligamentous balance. So your ligaments don't quite function right from your arthritis, and so not only do you have to put the implant in, you have to do sort of some soft tissue work to get the knee to function properly. So it was felt by the group of people that made that implant that if we would asymmetrically semi-custom make a knee replacement, that you could avoid doing the ligament surgery. Well, your ligaments have a problem from your arthritis, and they do need to be fixed. Well, it was a school of thought that maybe they did. So they were doing that for a while, and a significant number of people had problems with knee range of motion because their ligaments weren't properly balanced, so that's not done anymore.
So I'm hearing you say that when you do a total knee replacement, you do replace all the ligaments.
You don't replace the ligaments, you balance the ligaments. So the one ligament, your anterior cruciate ligament, is removed. It has to be removed for the geometry of the prosthesis. The other ligaments, in general, stay. Sometimes in special circumstances, those might have to be removed. But we do what's called balancing them. So on a big knock knee, the ligaments, so if your knee is really bow-legged, bow-legged knee, if your knee is really bow-legged out, your ligament on the inside gets very tight because it's been shortened for a long time, and the one on the outside gets very loose. So we have to do something to make those equal, otherwise your knee won't function properly.
Do you change the attachments, or do you just work with the ligaments then?
Both.
Both, okay.
Yeah.
How long does that Ibera shot or whatever it's called last? I know it's given before surgery, but it lasts longer. It helps
Yeah.
the recovery.
So it's an iovera. We do it about 2 weeks beforehand. And the main reason we do it 2 weeks beforehand, it can cause some bruising around your knee that we like to have gone by the time surgery comes. The company tells us it lasts 3 months, but I've been finding it lasts 4 or 5 months. That we like to try all the non-surgical things first. So we put you on medicine, we get you into therapy, we try braces, we try different shots. And if you're, despite doing all that, if your knee pain is negatively affecting your daily activities, say you can't go to Walmart or you can't go to Hy-Vee or something because your knee hurts too bad, and to be honest, I don't care how old you are.
How long before I can lift 65 pounds?
Well, to be honest, we don't have a lot of restrictions afterwards, so whenever you feel like it, you can do it.
As long as you what?
Whenever you feel like it, you can do it.
Oh, whenever you feel like it.
How long does the knee last?
The longest term study we have for knee replacements is a 20-year study saying 93 to 95% will last longer than 20 years. For hips, we have a little longer studies, or 30-year studies, saying that 80% of them are working at 30 years and 90% are working at 20 years.
Can you replace them more than once?
Yes.
In your knee?
Yes.
So replace.
More.
So I'm 60, so 40 years gets me to 100. I'd be good with that.
Do you take lifelong prescription medicine after this, or is there none prescribed?
That's a really good controversial topic. So the only medicine you take is what we call dental prophylaxis, or medicine to prevent an infection if you go to the dentist, or if you have other surgeries or something. Other than that, there's no like anti-rejection drugs or anything. So it's antibiotics. You take one high dose an hour before you go to the dentist. I have a sort of a different school of thought than people. I think you should take it the rest of your life. And the reason for that is that single dose antibiotics cost about $1. And it can prevent a lifelong disaster. So if your artificial joint gets infected, it's a very big problem. And you don't want to have that. So if we can potentially eliminate that problem by taking $1 worth of medicine every time you go to the dentist, it's worthwhile. The general guideline is that you should do it for 2 years after surgery unless you're at a high risk for having some other issues. But the general guidelines say you do it for 2 years after your joint replacement. You don't have to do that.
And that's antibiotics?
Yes. So when you go to the dentist, nobody realizes this, but there's bacteria in your mouth, and when you have a dental cleaning, that bacteria goes into your bloodstream. And if you don't have a big chunk of metal like an artificial joint or a heart valve or something to that effect, it's not a big deal. Your body just makes it go away. But when there's something artificial in your body, it goes to your bloodstream to that spot and will infect that spot. Any other questions?
What brand of knee do you use?
I use a brand called Zimmer Biomet. It's called two names because they used to be separate companies and they're joined.
You don't ever do anybody over 80 years old?
That's for outpatient surgery. Yeah, inpatient surgery, we operate on a lot of people.
If you're having trouble with both knees, it's better to do one and do another one later, or?
I have the bias that it's better to do one and another one later. But then you have a discussion about what later means. And so that varies a little bit. I currently do them somewhere between 1 and 2 months apart. I kind of tell people that 50% of a knee replacement is the knee replacement and the other 50% is the therapy. And if people don't do the therapy, they might as well not do the operation because you'll be worse afterwards than you were beforehand. So therapy is very important. In the first couple weeks, it's not a lot of fun. But you got to do it, you got to bite the bullet, you got to get it done. And some people, when they have 2 knees, just say, I want to get it done as close as possible, I just want to get all the misery over with and get better. Other people say, I just want to do one at a time, and if they want to do more one at a time, I usually do them 8 weeks apart because you'll be plenty over the first one and get the other one done. Other people, if one just bothers them a lot, the other one doesn't bother them hardly at all, we just won't schedule the other one until it bothers you enough. But there are certain things like getting up and down out of a chair, going up and down stairs, climbing up and down hills. You really aren't going to be able to do that until both knees are done, because it takes 2 knees to do that sort of
To
stuff.
see you, to make an appointment with you, I need to refer for my PCP doctor first,
No,
so I can make an appointment.
For hip replacement, are there different methods to do it? And is there one that you prefer?
So when we talk about methods, there's different surgical approaches to it. There's different implants that we use, and there's different ways the implants bind to the bone. So there's all kinds of different things. So we'll start out with approaches to the hip. So there's two general ways to get into a hip. There's what's called an anterior approach and a posterior approach. The posterior approach means from the back, and the anterior approach means from the front. There's been a boatload of stuff in the literature, or in the lay press, saying how much better an anterior approach is than a posterior approach. The bottom line is this: there's been also a boatload of studies done in our literature comparing the two approaches, and there's really only one difference. So one of the risks of hip replacements is a dislocation, a postoperative dislocation, meaning a ball comes out of the socket. There is a significantly lower risk of a postoperative dislocation with an anterior approach than a posterior approach. The risk, however, is low. It's around 2 or 3% with a posterior approach and well less than 1% with an anterior approach. So the risk is still low. However, an anterior approach, the risk is a lot lower than a posterior approach. Everything you read about quicker recovery, less blood loss, less pain, less risk, none of that's true. That's the only difference between the two approaches. The next part is how you put the prosthesis in there. So they either go in cemented or uncemmented. The majority of knee replacements are put in cemented. Most hip replacements will put nowadays uncemmented. That means the bone has to grow into the prosthesis. Your bone quality has to be reasonable for that, however. So if you have bad osteoporosis, that won't work, and so we'll cement the prosthesis in. That's kind of an intraoperative decision on which way you have with that. Once it's in, you don't know the difference. I mean, you can't feel the difference between the two. But still, probably 90+% of the time, they go on uncemented. And then the only other thing we talk about, which we talked about there a little bit, are ceramics and metals and newer types of plastics. So for young people, we usually use more ceramics and the newer types of plastic. We know that the traditional plastic and the metals last a good long time, meaning over 20 years. But if you're replacing somebody's hip in their 40s, you'd like to try to get that obviously to last a lot longer. So they more commonly will have the ceramics and maybe a newer type of plastic or something else to make sure.
Is there any complications from your point of view of where those scars are and how we can do the knee replacement?
The old scars are different than the new scars, meaning that they used to do these things a little different than we do now. We have to look at where your scar is to decide if we try to use the old scar, but the old scar has to be in a reasonable spot. And so we try to do that. If we can't do that, we make a new scar. The scars in general can't form a V, meaning that they can't come down and join together. They come at a right angle, but they can't come in an acute angle. And the reason for that is the blood supply to that skin in there will have a problem. So we don't do that, so we either scoot the one over really far or just use the old way this one.
Are Baker's cysts common before knee problems? Are they related?
I'd say almost everybody's got a Baker's cyst.
Everyone?
I say almost everybody does.
So
what a Baker's cyst is instead of when your knee swells, it will either swell out the front where you can see it, or it swells out the back. When it swells out the back, we call that a Baker's cyst. A Baker's cyst can come from anything abnormal inside your knee. So if you tear the cartilage, it can come from that. If you sprain a ligament, it can come from that. If you tear a ligament or whatever, it can come from that. With arthritis, it comes from that. In the old days, I tell people this every day, that before my time, they used to make this big S incision down the people's knees in the back of the knee, and they took out all the Baker's cysts. Well, they all came back because they didn't know where they came from, so that's not done at all anymore. Until the problem inside your knee goes away, your Baker's cysts will not go away. Now, they can get bigger and small. They can get so small you don't know they're there, but they are still there, and then get bigger when your arthritis flares. At the time of your knee replacement, they get evacuated from inside out, and that makes them go away.
You gave us a list of surgeons here. Are these guys so busy that it takes a while to make a decision to go ahead and have the surgery? How long will it take before it's actually getting
The decision to have surgery?
Yeah. I mean,
Well, I mean, all surgeons are different, and they like to do different things prior to surgery. You know, so they, you know, if you come in with bone-on-bone arthritis, you're debilitated, you tried, you know, your family doctor's giving you a shot, or you tried some therapy, and you just can't function, usually in the office, you decide you're going to surgery that day. You know, that it takes a variable time period before your surgery actually gets done. You know, just based on how busy the surgeon is at the time, but that is very large.
Why does your knee lock when you walk?
Why does your knee lock?
Yeah.
There's a lot of reasons for that. It can lock from arthritis, it can lock from a cartilage tear. If your knee's unstable from a ligament tear, it can lock. Some people just get that sensation from pain that it's locking when it, you know, manually isn't doing that. But sometimes, you know, just the most common thing is a torn cartilage that can flip into an abnormal spot and cause locking. I'm talking about cartilage, I'm talking about the thing called the meniscus, and that's what can cause that.
Do shoulder bone spurs come back after you've removed them?
So if you remove them at the time of a joint replacement, the answer is no. There's other kinds of bone spurs in a shoulder joint, something we call subacromial spurring or acromioclavicular spurring. It has nothing to do with arthritis in your shoulder. Those we do remove, like at the time to rotate a cuff tear or something. Those can come back, but you know, I can't tell people if you're 60 years old and it took 60 years for them to get there, it's going to take 50 or 60 years for them to come back, so don't worry about it. You got it? Go ahead.
This is regarding the hip replacement. What determines where you make the incision? And about how big is it? I remember years ago it was more on the side and it was really long. Now everybody's saying minimally invasive.
So traditionally back in the day and the way I was taught, most people were taught there were 12-inch incisions. That's the way the hip and knee replacements were done, was a big incision, so you could see everything adequately. Our instrumentation and the way we do things is a lot better now. I personally do all the minimally invasive surgery, so your hip incision for me is about that big. We tell people we make it as small as possible to get the implant in there appropriately. The placement of the incision is surgeon directed. So they put the incision where they feel comfortable to do the approach to getting you in.
How about cutting through muscles? They
When
do much of that anymore?
When any human being tells you they're not cutting through muscle, they're not telling you the truth. So anytime you get into any joint, there's muscle surrounding the joint, and you have to not necessarily cut through the muscle, but you have to remove the muscle from the bone to get into the joint. Because there's different layers to get into a joint, and there's a muscle there. So we do minimize the amount of muscle we cut or remove to aid in the recovery.
Typical knee surgery that goes well, everything goes well, how long is the surgery?
Hour.
I mean, from cut to finish, an hour? Okay.
So I schedule those for an hour and a half. What's meant by that is room time. By the time you get in the room, you get your anesthesia, you get prepped and draped. Out of the room, it's an hour and a half. We use a tourniquet for knee replacements usually. The tourniquet goes on right before the skin incision and goes off after all the dressing is on. It's right a little less than an hour, 55 minutes.
Thank you.
The knee replacement surgery, is there physical therapy before the surgery?
I don't know if there's any therapists in the room, but the therapist thinks there should be. No, we can show you a couple of easy exercises in the office, but there hasn't been really shown to be any benefit of pre-op supervised physical therapy. You know, there's a couple exercises you could do that may potentially help a little bit. I kind of think this riding a stationary bike is a really, really good thing to do before and after surgery. But there are a couple exercises you could do that won't hurt. So when I'm talking about the BMI thing, I'm talking about studies that were done in hip replacements and knee replacements only. So we're not talking about finger surgery, rotator cuff surgery, gallbladder surgery, heart valves, anything. It's only hip and knee replacements. And there's been an exhaustive amount of studies done on that. And there's no question there's an increased risk for perioperative problems with infections, wound healing problems, blood clot problems, pneumonia problems. Well, say you get through everything perfectly fine, and you do well and everything's fine. Part of our restrictions, as we talked about, was not carrying heavy weights. When you're overweight, that's like carrying extra, stuff every day on a regular basis. So again, the artificial joints are made out of metal and plastic, and they're not designed for that high impact use. So there's also been shown to be a decreased longevity of the prosthesis in people who are overweight. And it may not seem to you like it's an elective operation, but they are. And there are major, if I can't express to you enough, if an artificial joint gets infected, it's a life-altering disaster. You don't want that to happen. And the risks of that when your BMI is over 40 is exponentially increased compared to when it's below 40. And we don't want to have that. Nobody wants to have that. And so it's in the patient's best interest to lower their body weight to decrease the risks and complications around the time of surgery, as well as to have that prosthesis last as long as possible. And I know it's hard to lose weight when you can't walk. So my 3 favorite exercises for people to do with hip and knee arthritis are walking, biking, and swimming. Of those 3, I understand walking gets to be too difficult. So I encourage people to get a stationary bike. You can sit on a bike. Your knees won't see your body weight. You can pedal the bike. You can get into a swimming pool, which sometimes is more difficult, but walk in a pool, kick in a pool, do something to get up your heart rate to try to burn some energy. And obviously diet's the other thing. And I understand all those are hard, but that's just the way it is. All right, thanks everybody for coming.